While that's open, I just want to add a point. In the first studies, paravalvular leak was shown as a negative prognostic factor, for survival. And as you see, these later valves have all been designed to prevent paravalvular leak. And they also, you see a concomitant rise in the pacemaker rate. So you can't have it all. But that's sort of what we've seen. So let me try to work this here. All right, well, thanks for having me. I'm Jeff Gaca, like Kevin said. I'm one of the heart surgeons, and I'm one of the TAVR, work with the TAVR, work closely with all the cardiologists who like to see so many friendly faces I haven't seen in a while. People come from far places. Thanks for coming. So we're going to talk about something that almost never happens. Just kidding. Treatment of failing bioprosthesis. I don't have any financial disclosures, but we will discuss off-label uses of an FDA-approved device, so plug your ears during that. I'm just kidding. All right, so let's do a case because I think it's more interesting that way. So this is a real case that we did. It's an 84-year-old woman who had a bioprosthetic AVR, a Baxter porcine valve in 1992, and when you're dealing with bioprosthetic valve failure, the thing that you really need is information. And it's hard to get information from an operation in 1992. So we have no idea what size valve this is. We just know op note says Baxter. Okay, fine. She has class 3 symptoms. She has severe bioprosthetic valve insufficiency, and that'll be important later. A mean aortic valve gradient of 22, severe MR, LVF of 35, moderate pulmonary hypertension, moderate TR. She was seen by a couple surgeons who thought she was high risk for a redo MVR, possible TVR. So we did some investigations, and this is what I mean. This is a CT scan. This is a slice of a recon CT scan. This is us trying to figure out how big this sewing ring actually is, because that has implications for how we treat this woman. So the best we can deduce, she has an 18 millimeter orifice area in this valve. And this is her shots from her echo. Is this playing? Oh, good, great. So she has severe AI. She has MR peeking in there too. And I'll talk about this a little bit later, but what's really important in bioprosthetic valve failure, especially insufficiency regurgitation, is to determine whether it's intravalvar or paravalvar. Because if it's intravalvar, we can help that. But if it's paravalvar, TAVR's not going to do anything for that. Oh, whoops, there was a problem. Oops, okay, I'll try again. Oh, rats. Here we go. Okay, so we'll go again. Those are big. So anyway, so then this is another shot of the MR. So we could go, full speed and do the whole thing, or we could treat the aortic valve, and we thought treating the aortic valve would be the best choice, and this is how we treated it, valve and valve. And you can see here, this is actually a Sapien XT, and this is the valve stent frame. You can see here that each valve has its own distinct radiographic appearance, and that'll become important, as you plan these cases. And these cases are actually very technically not that difficult because the valve frame provides your landing zone for a TAVR device. And you use very little dye. You don't have, the implant angle is very easy to find. So, and this is how it looked at the end. We shot a gram and voila, no regurgitation. Looks great. And you can see how that stent frame is indented there. It's bent on the post of that valve. And you can see the mean gradient afterwards, 10. That's an absolutely outstanding result. So very happy with that. Great use of this technology. So where do we stand now in 2016 in surgical aortic valves? Well, bioprosthetic valves in the aortic position account for 80% of all valves implanted. Nobody wants to take Coumadin. They sometimes have to, but nobody wants to. The freedom from reoperation for a failing bioprosthetic valve at 5 years is about 95%, 10 years 90, but 15 years 70%. So lifetime incidence of reoperation in a patient who's 50 is 45% and then falls at 60 to 25%. And this is another way of looking at it. You can see here, you put a bioprosthetic valve in a 50-year-old, their reoperation rate is high. There's a great chance that they'll need another operation in their lifetime. And obviously it's stepwise progression downward as you reach 75. So what's the durability of aortic bioprosthesis? We have a bunch of different things here, but you can see the autograft, the homographs, and the stentless valves. There's not a lot of data on them, but you can see in about 12 to 15 years, the stented valves, the CE pericardium valve, the CE, the BioCore Hancock 2, they start falling off. So what you tell patients is 10 to 15 years. Maybe they'll get lucky and get 20 out of it, but really 10 to 15 years is what you tell everyone. And they all want to know whether I'm 10 or 15. I always say you're 15, no doubt about it. So, another thing, and I think this is sort of where the heart team approach comes into play here, is you really have to know your types of valves that are implanted, how they function, what their stent frame looks like, where the leaflets are mounted. It's very, very important. And these are stented valves here on the top. These are the majority of valves that are implanted, almost 95% of the valves that are implanted. They have a rigid stent with a sewing ring that we can put the sutures in, and the valve leaflets are mounted on there, okay? That rigid stent is what's going to hold that TAVR device and limit the size of the TAVR device you can get in. Now, it's important to note here that every single one of these valves was designed before TAVR was even thought of, okay? So I know that today they're trying to design surgical aortic valves with valve-in-valve TAVR in mind. But none of these, we're retrofitting this technology. None of these, when they were designing these valves, no one thought of TAVR. Like, that was not gonna happen. So you have to know your kind of valves. And there's more valves than this, but this is pretty much what we use. And each valve has a distinctive radiographic appearance, and you have to know that. There's an interesting story that came out of Europe that, if you can see this valve over here, which is D, valve D, which is a mosaic, you see it has these three little dots at the top of the post, these three that's not where the sewing ring is, and where you put the TAVR device. And there's a story of these people trying to implant it at the level of the top of the posts here, and the valve they deployed it and it just flew away. It just went down because they didn't know where it was. So you have to know that in each one of these, and now I know by looking at H that's a CE paramount, but that you have to know. And like I said, these valves were not designed for TAVR, but we're retrofitting it. And then another thing you got to realize is not all valves are created the same. What are the dimensions of a valve? When you say that a person has a 25 millimeter valve, that is the outer sewing ring diameter. That's the reported size of the valve. And not all these are the same. The outer stent diameter is A, the inner stent diameter B. That's what matters. That's the orifice area. And that's what our TAVR valve has to fit in. And not all valves are created the same, surgical valves. And a 23 millimeter porcine valve may have a worse inner diameter than a 23 millimeter pericardial valve. And you may get two very different results from those procedures, and you have to know that. And interestingly enough, the manufacturers aren't really interested in you knowing that, because this is a big deal. And what they report may not be actually what it is. And so you can see here that a Sorin MitraFlow 21 millimeter valve has an inner diameter of 17.3. It's really 17. A Magna Ease has an inner diameter of 20, but it's really 18. So those are small valves, and that's going to limit your effectiveness in treating those people. Larger valves, much better results. So how do these bioprosthetic valves fail? Sometimes they just wear out. They get regurgitant, like in panel A there. There's a hole in the leaflet. Severe AI. Calcification, they get pannus, they can get endocarditis, they can get thrombus, and that's what John's going to talk about, either acute or chronic. Obviously, we're not treating anyone with endocarditis with TAVR, but that's how these valves fail. What's a reoperation for failing bioprosthetic valves? The operative mortality for reoperative surgical aortic valves is between 2 and 7%. And it's really misleading to say that high risk and non-elective patients, this can be high as 30%. It really can, but those are people who are dying. These are people with root abscesses. That's a whole different ballgame. And we don't really treat a lot of people in that category with TAVR. But I'd say 2 to 7% for redo AVR. So I think this is the VIVID registry, which is the valve-in-valve international data registry, is really the sort of the best, I think, sort of information about what happens to failed bioprosthetic valves. They looked at 459 patients over a 6-year period. And I think it's really interesting here to look at this. And people who had the highest death rate of any cause after TAVR were those who had their valve, bioprosthetic valve, failed by stenosis. In other words, if they had stenosis of a bioprosthetic valve and they got TAVR, they had the worst clinical outcomes. The combined people were intermediate, and the regurgitant people actually had the best clinical outcomes. And that means the mode of failure of the bioprosthetic valve affects survival even after valve-in-valve TAVR, which I think is pretty interesting, and we'll get to a reason why. And there was no difference. You can use balloon expandable or self-expandable. At least in this trial, there was no difference in survival in using either device. But this is, this 2007 to 2013, that's got to be considered era one for this technology. This is the initial experience. So then, this is sort of where the rubber meets the road. They grouped people into small valve size, which was bioprosthetic valves 21 millimeters and under, intermediate bioprosthetic valves 21 to 25, and large bioprosthetic valves 25 and greater. And the survival was dictated by valve size. Small bioprosthetic valve patients had worse survival than intermediate and large. And the overall mortality was about 7%, which is in line with redo AVR. But like I said, 1 year survival in people who had small bioprosthetic valves was only 75%. That's not really good. That's 25% mortality. That's not great. 81%, it gets better though. 81% with intermediate, 93% with large. So it's clear that something's going on here. And the statement, I think this is really interesting. People who failed surgical valves by stenosis should be further separated into those who have degenerated surgical valves and those who have elevated gradients due to patient prosthesis mismatch. So what that means is if someone comes into your office and they have a small surgical valve and they have an elevated gradient, it doesn't mean that that valve's failing. That valve may just be small and the leaflets may be moving normally. And if you put a TAVR in that patient, you are going to do absolutely no good. But this can be difficult to distinguish. And these people with patient prosthesis mismatch will not benefit from TAVR. And I think they represent the bulk of the operative mortality from valve-in-valve TAVR in that small prosthesis group. Really difficult group of people to treat. Very difficult. So I would say, let's go over some basics here. Be wary of valve-in-valve and small valves. You may not get the result you wanted. Valve-in-valve TAVR will not help paravalvular leak, and you might need to get a TEE or further imaging, and absolutely know your surgical valve type. You got to know how big it is, what the orifice area is, and where to put it. So, since it's 2016, all that information is on your phone, right? So these are screenshots from my phone. There's a valve-in-valve aortic app and a valve-in-valve mitral app. And you know what? It's really accurate, and it works great. And you can see on the left panel there, you look up, this is a CE standard, and you can see it has a little screenshot of the radiographic appearance, so you can make sure that's what it is, because sometimes the op note just says aortic valve. I mean, you have no idea. And they could be operated on, 20 years ago. And then you pick a 23, and it shows you the true internal diameter is 20, and you go over here, and these are the valves that you can use. And some of these, look, you have some not recommended and things like that. So there's an app for that. So these are some slides I stole. There are some technical things that you can do to make things a little bit better for valve-in-valve. And this talks about implant depth. If you have a higher implant depth, like a core valve, the valve can actually sit above the stent frame and can actually, so you don't sort of get it inside. You don't get the valve leaflets inside the sewing ring and get them constrained. And you can see here when you do that, you get a better gradient, and you can have higher gradients if you have low implant depths. So this is stuff we're getting better with. And you can see the same thing can be done with a Sapien. A low implant is bad on the right there. A higher implant is a little bit better. So this is stuff we're learning. Like I said, we're still in the early phase of this. And the same thing you can see here with Portico as well. So implant depth matters, especially in small valves. So that's just some technical things that maybe make these things better. So I wanted to, talk a little bit, maybe a little what Andrew was talking about. So we have another case, and any surgeons or cardiologists in the room, this would be great. So this is an 83-year-old guy who had a bioprosthetic mitral valve replacement in 2004, and then in 2011, I did a bioprosthetic aortic valve replacement on him, and I swear his mitral valve was fine in 2011. I swear, it was totally fine. He's had a lot of problems, AAA repair, cervical spine fusion. PCI, atrial fib, creatinine 1.7, pulmonary hypertension. So we're looking at a third-time redo for severe bioprosthetic mitral stenosis and class 3 heart failure symptoms. So we thought maybe that's not such a good idea. So this is the close your ears, not FDA approved portion of the talk. So there's an app for this too. Look at that. So Paramount, you can see the classic radio opaque appearance of a Paramount there. And you can see it tells us we should use a 26 Sapien for this 25 Paramount. The true internal diameter is 23 millimeters. And this is a couple of our shots. This is our measurement. We're confirming it by CTA there. And you can see the TE images here. That valve leaflet's like, those leaflets are not moving. Doesn't look great, right? And we did transapical approach, and we blow up our valve there. You can see the mitral valve here, the aortic valve above it. And we were really happy. Look at those leaflets now. It's always good to see pretty pictures, right? So 3D TE shows a great result. Our pre-gradient was 12, our post-gradient was 2. And that's on the mitral side, that's a big difference. That's a huge improvement. And this guy's doing great. So valve in the non-aortic position. It can be performed for failing bioprosthetic valves in the mitral, either transapical or transfemoral, transeptal. Tricuspid, transvenous, which we've done as well. Pulmonary, it can also be done transvenous. This is off-label use. Not a lot of long-term data. Results are lacking. Reports in the literature are small series. However, it remains an attractive option in extreme high-risk patients. So here's a 5-year experience, 23 patients. We wrote up our series, it's 5 patients. It's interesting, this is a transapical series, and one major stroke, 4.4%, but 6 major bleeds. That's anything you do transapical has a risk of bleeding because the apex can fall apart. And when that bleeds, it's major. So 26%, that's pretty high. That's why we try to stay away from transapical if at all possible. No operative deaths and great survival at almost 2.5 years. And you can see here, are very effective in getting rid of mitral regurgitation for a failing bioprosthetic valve. Transvalvular gradient, it will reduce it. And it's different than the aortic valve. If you reduce a transmitral gradient by half, you've done a great job. Those people will feel a lot better. So I just want to have a few slides to talk about the conclusion. Heart team approach is ideal environment to evaluate and treat. You need cardiology, you need anesthesia, you need surgery, you need echocardiography, imaging, radiology, everybody to help you with this. Accurate diagnosis in imaging. If you don't know the valve you're treating, if you don't know the size, don't do it. And unanswered questions. There is a ton of people out there with failed bioprosthetic valves. And valve TAVR is a great therapy for intermediate large size valves. What's the best treatment for small bioprosthetic valves? Interesting. Patient factors, advances in technology, and further research will hopefully answer this question. With the beginning of the low-risk randomized trials, the effect of a valve TAVR becomes very important. What do you do with a young patient with aortic stenosis? Do you do a mechanical valve, SAVR? Do you do a bioprosthetic valve, SAVR? Or do you do a TAVR? If you look at a young patient and you're going to put a 21 millimeter bioprosthetic or 19 millimeter bioprosthetic valve in, I think you should really think hard about doing that. Because those people will need another valve in their lifetime. And this is my favorite slide here, because I used to play with these when I was a kid. So the first choice when you have these patients is the most important choice, because it has serious implications for later treatment. There's only so many valves you can put in a valve, or else you turn into the little doll in the middle. So there's a limit to that. Thanks a lot.